Good morning. First, I would like to thank Badulla Clinical Society for inviting me to give this talk on uh, fatty liver. So, to start with, uh, I would like to share my slides with you. So, what is fatty liver and what is non-alcoholic steatohepatitis? Fatty liver is accumulation of fat in the liver. Non-alcoholic steatohepatitis is when it is associated with inflammation. Non-alcoholic steatohepatitis is a complicated metabolic liver illness, and at the same time, it's a multi-system disease. What is progressive NAFLD? Progressive NAFLD is the most important form of fatty liver, that is the fatty liver leading to non-alcoholic steatohepatitis, fibrosis, cirrhosis, and hepatocellular carcinoma. And it consists of about 10% of the total patients with fatty liver. So we can expect 1 in 10 patients with fatty liver to end up with cirrhosis and hepatocellular carcinoma that consists of what's called a liver related mortality. Breast will not progress to advanced liver disease, so this is called non-progressive NAFLD, but unfortunately that is also kind of a serious illness, because even there, though the liver mortality is insignificant, cardiovascular mortality is still high. So what does it mean? If you have a fatty liver, you have a higher mortality than a patient without fatty liver, and this is true for any rise in the ALT. So if you see a patient with, or a person with seemingly well person, asymptomatic person with elevated liver enzymes, mainly alanine transaminase or ALT or SGPT, that person is more likely to die from an illness compared to a patient with or person with normal ALT or SGPT. So this is well known in the insurance sector for many years, and even 20 years ago, uh, if a person has elevated SGPT, they used to increase their premium for a life insurance. Uh, so again, is it safe to have non-progressive NAFLD? No, I told this emphatically in the previous slide. No, because of the high cardiovascular risk, high malignancy risk, uh, risk of dying from any other illness, dengue fever, and recently I got to know that even pregnant females are at risk of liver rupture during pregnancy if they have fatty liver, and they can't donate a liver even if you need to donate a portion of your liver to say your child, because of this disturbed microcirculation, and this liver will tolerate ischemia very poorly. So that's why the mortality is increased in dengue, and also they can't be liver donors. And difficulty in obtaining life insurance, I have told you before. And even these patients with what's called non-progressive NAFLD will have to their liver screened every 3 years, especially if they have high risk factors, middle age, obesity, metabolic syndrome, diabetes mellitus, family history of cirrhosis and hepatocellular carcinoma. They should get their livers checked for evidence of progression. So I will talk to you the best evidence that we have at the moment is the calculation of Fib4 score or fibrosis 4 score and then a fibroscan. So I give you an example of a increased mortality in patients with fatty liver. 32-year-old obese mother of 2 young children with poorly controlled diabetes develops rapidly rising liver enzymes and high lactate levels during late leaking phase of dengue hemorrhagic fever while maintaining a reasonable urine output. AST rises to 20,000 on around day 6, but unfortunately she succumbs to her illness with multi-organ failure on day 7. So this is acute liver failure, hyperacute liver failure to be precise, and this is probably because fatty liver tolerate ischemia very poorly. So this is well known that non-alcoholic fatty liver disease is associated with increased hemoconcentration, thrombocytopenia, and longer hospital stay in dengue-infected patients with plasma leakage. So raised ALT, what's the normal ALT? For males, it's 30, and for females, it's 19. So if you take a female, 40-year-old female with ALT of 40, according to current concepts, she may be having ALT of twice the upper limit of normal. So be careful when you are interpreting ALT levels in your practice, and also be careful about the laboratory because some of the labs are very not very reliable, and when you are taking treatment decisions like say calculating the Fib4 score, and make sure that you always rely on a reliable lab rather than a lab that you find next door. So what does the elevation mean? As I told you before, it causes all-cause mortality and also increased liver-related mortality. So it's not nice to have a ALT of 60, 70, 80, especially in a young patient, because it's probably going to reflect some kind of increased mortality in the future. So I told you about this life insurance saga. So what really happens, you are born with a normal liver, and if you are lean, you may be having a very normal liver, but say maybe due to your fast food intake or energy excess, you may be having a fatty liver around the age of 20. Then due to various other factors, host factors like genetic susceptibility, then gut microbiome issues, or what's called dysfunction of your microbiome, which can lead to various toxins being produced, getting absorbed, and initiating inflammation in the liver. So various secondary hits can lead to end up with cirrhosis around 50 years and maybe hepatocellular carcinoma 5 years later. So your NASH or inflammation may be initiating around the age of 20, but you may be having your cirrhosis around 50, 60. So each step from normal liver to fatty liver to non-alcoholic steatohepatitis, non-alcoholic steatohepatitis to fibrosis, fibrosis to cirrhosis, then the development of hepatocellular carcinoma. Each step may be taking as long as 10 years. So what I want to emphasize this fact is that you have enough time to act, so can prevent or delay each and every step till you die from a liver-related cause, that is decompensated cirrhosis or hepatocellular carcinoma. So most important thing is to identify these patients. The moment you start having a fatty liver, you make sure that you identify these patients and you can initiate uh, corrective measures so that that can prevent them from progressing into the next step. So what are the major contributors? Insulin resistance, lipotoxicity, ectopic fat. So liver fat is ectopic fat. Liver is not an organ that is made to store fat. It's adipose tissue, but if you have fat elsewhere, not in the adipose tissue, so it is called ectopic fat. Ectopic fat is toxic to the liver and elsewhere. So that's why you get fatty liver, get a myocardial infarction. It's toxic not only there, and because it's toxic elsewhere also. So then gut dysbiosis. So all these changes in the gut microbiome brought over by the use of fructose, saturated fats, antibiotics can lead to various changes, and which can lead to accumulation of various toxins generated by changes in the liver leading to inflammation. So what are the other associations of fatty liver? See everything: diabetes, IGHD, CKD, hypertension, malignancy, polycystic ovary syndrome, polycythemia. So it's a multi-system disease. It's not only fibrosis is uh, progressing in the liver, and at the same time, if someone is having fibrosis in the liver, at the same time, the patient is more likely to have some kind of atherosclerosis, and myocardial infarction is common in these patients. And majority of patients die of cardiovascular disease. What's the liver-related mortality? We encounter that only in the progressive form of the fatty liver, that is NASH, fibrosis, cirrhosis, and hepatocellular carcinoma. And this group consists only about 10% of the total population with fatty liver. And the single most predictor from liver mortality is the stage of fibrosis. So in other words, if you don't have fibrosis, there will be no liver related mortality. But if you have some kind of fibrosis, whether stage 1, stage 2, stage 3 or 4, then your liver related mortality increases accordingly. But one thing that we can surely tell you that the most important predictor of liver fibrosis is not the transaminases or the ultrasound scan grade. So we just cannot tell exactly how much fibrosis is there by just doing the AST/ALT or the ultrasound scan. So we need a different approach to identify the patients who are at risk of developing cirrhosis. So in other words, who are the people who have advanced fibrosis at that particular time. So it's not the transaminases, it's not the ultrasound scan. So that's the point that I want to emphasize here in this slide. So what are the clinical predictors of fibrosis? The age, diabetes, sex, female sex after 50, obesity, and family history. So NAFLD is a silent killer. So till even in the United States, these people with fatty liver do not know that they have cirrhosis or impending disaster till they present with some kind of uh, presenting symptom due to decompensation, which include hematemesis, ankle swelling, ascites, or even hepatocellular carcinoma. So even in the United States, most of these patients will present with fatal event. Till that time, they do not know. It's asymptomatic, and they have no idea what's going to happen to them. So they are asymptomatic till they present with hematemesis. They are asymptomatic till they present with hepatocellular carcinoma. They are asymptomatic till they present with ascites. So NAFLD is a silent killer. So that's why it's important for us to uh, look for advanced fibrosis in patients who have fatty liver. So the emphasis should be on the non-invasive markers, how we are going to detect these patients with patients who are at risk of advanced fibrosis non-invasively. So just can't be biopsying all these people. So we have to have non-invasive methods. So there are quite a few non-invasive methods like serological markers or imaging techniques. We'll take one by one. This is the most widely used, what's called the Fib4 score. This is in most of the guidelines now. It's a simple calculation. It's available free online. They calculate the age, the AST, the platelet count, and the ALT value. And if you have those values, you can predict fibrosis. I'll give you 4 examples. Example 1, young boy with AST of 80. This is very common, this kind of presentation, normal platelets. The Fib4 is 0.56, and if it is less than 1.45, the risk of fibrosis is minimal. So these patients can be repeated with non-invasive markers in 2 to 3 years time. This is a slight change. Now older patient, ALT has come down a bit, 60, AST has gone up. This is very significant. Rising AST is very significant. Platelets have dropped just a wee bit. So here the Fib4 score is 2.17. So that patient needs a fibroscan because it's more than 1.45. When it is more than 3.5, that is cirrhosis. But this is intermediate. So this patient needs a fibroscan. So this is another example. It's totally reversed. AST 80, ALT 40. So AST has gone past ALT, that is bad news, that is fibrosis, and the platelets are also down. The score is 7.87, that is cirrhosis. And another example, just took this because they are within normal range. So AST-ALT within 40, so-called normal range. Still see the difference. AST is higher than ALT. Age is 60, platelets low. So this is 3.39, that is cirrhosis. These are 4 examples I want to give. So then the people who have high Fib4 score should be sent for what's called a fibroscan. Fibroscan is something similar to ultrasound scan, and it's very easy to do a fibroscan, operator friendly, non-invasive, just few minutes. The patient just have to be fasting, and that will give you a score like this: 204 and 3.5 in this report, and the second report 209 and 33.3. So the blue uh, uh, value is for CAP score, that's the amount of fat, which is 204, that is not bad. Then this yellow score is for the stiffness, that is in kilopascals. It's called liver stiffness measurement score 3.5, that is normal, and if it is more than 8, then it is fibrosis, more than 12 cirrhosis. So 33.3 in the second reading, that is cirrhosis. You should be familiar with these scores, the CAP score and the liver stiffness measurement. So when the liver stiffness measurement is more than 8 and less than 12, it's the area that we are concerned, and that is the area where I need a biopsy to confirm fibrosis and then start treatment. So there's something new, both involving both the CAP, the AST level, and the fibroscan readings combined, and this is a fast score, and it may be better than the FIB4 score, but still it does not come into the guidelines. This is an algorithm, a very recent one, of what we should be doing when we have a patient with fatty liver in the primary setting. Search for other diseases like alcohol abuse, viral hepatitis, and if there is nothing like that, then do the calculate the FIB4 score. If it is less than 1.3, low risk, and lifestyle changes, and repeat the score at 1 year. If it is more than 1.3, refer to the tertiary center for a fibroscan. If the fibroscan says the liver stiffness measurement is less than 8, then again lifestyle changes, and if it's more than 8, it's high risk and do a biopsy, and if there is evidence of steatohepatitis or fibrosis, then the patient will be started on what are called liver directed therapy, that is drug treatment for non-alcoholic steatohepatitis, which is progressive NAFLD. So drug therapy is reserved for these patients who have progressive form of the disease only. So we generally do not give drugs for patients with non-progressive form of the disease. So how do you treat NAFLD? Pharmacological and non-pharmacological methods, and treatment of other risk factors. We need weight reduction of about 7 to 10%. We need calorie deficit and exercise, and all patients with NAFLD need these treatment options. And here the weight loss pyramid, and here we know that if we can lose more than 5 to 7% of the weight, and especially if we can lose up to 10% of the weight, there is resolution of NASH and reversal of the fibrosis. So what we should concentrate is to make the patient reduce weight somehow or other. So it doesn't matter how you do it, but the patient should be losing weight. So at least you need, according to this study, about 750 kilocalorie deficit. So if your calorie requirement is 2,500 a day, the dietitian should be able to calculate that for that particular patient and reduce 750 and make sure that you let the patient have a diet of 750 kilocalories less for 1 year. Then usually they achieve some kind of weight loss. But even in this strict regime, only 30% achieved significant weight loss. And why we can't lose weight? Because obesity is a complex neuropsychological disease, and calorie reduction leads to energy conservation. So it's not that easy to reduce weight. And bariatric surgery has a place in weight reduction, but at the moment it is not recommended for all people with NASH, but it is recommended only if the other indications for bariatric surgery are present. So we have various guidelines on how to and when to do bariatric surgery, but if you have fatty liver plus other indication, that's a good method of reducing weight and also improving your non-alcoholic steatohepatitis. You should have a dietitian to guide them, and should be low calorie, low saturated fat, low in processed meat, low refined sugar, and low added fructose and fast foods. So the DASH diet, hypertension diet, and the Mediterranean diet, and we should have Sri Lankan adaptations of these by a dietitian. I don't think we have a proper Sri Lankan adaptation of these beneficial diet uh, plans, but I think we should move towards, identifying the kinds of food that we can take to improve our fatty livers. So fructose is, which is the sugar we find in fruits, but made artificially nowadays, and this can lead to addiction by children and leading to the epidemic of fatty liver. Now they call it fructoholic liver disease. This fructose is as bad as alcohol. It's like taking alcohol. It's addictive and causes a fatty liver, leads to cirrhosis. So sweets in childhood is disaster. So you should not be eating sweets as a child, but then we make sure that your children do not take excessive sweets because it can be addictive and can end up with very bad liver consequences. Smoking should be reduced and coffee is beneficial, and we should all encourage these patients with fatty liver. Exercise is beneficial and moderate to rigorous any kind of exercise is beneficial, and we should encourage them to uh, uh, do a lot of exercise. The recommendation is exercise in fatty liver, just do it. Alcohol consumption is not recommended, and if you have lean NAFLD, what you should be doing is to make sure that you stick to the correct diet pattern and continue your exercise regimes, and even a small degree of weight loss is going to improve their livers. And probably lean NAFLD is more genetics or uh, changes in the gut microbiome more than anything else. So even still the management plan should be the same. Pharmacological therapy, not a lot. Diabetic drugs are there. Pioglitazone, saroglitazide is licensed in India. GLP-1 agonists, obeticholic acid is not a diabetic drug, but all these are beneficial in studies, but they have not been recommended by the FDA. But India approved saroglitazar. It's pioglitazone-like anti-diabetic drug, and that's the only drug licensed anywhere in the world. And vitamin E was found to be beneficial with pioglitazone in the PREVENT trial, and pioglitazone is coming back in the treatment of fatty liver, especially if you have diabetes. And obeticholic acid was presented the data, but it was not given the approval by the FDA this year, but it's good for NAFLD with fibrosis. And FDA rejected obeticholic acid this year, but I think the entire results are not still out, but maybe they may be getting the recommendations in the future. And the weight reducing empagliflozin and an anti-diabetic drug, SGLT2 inhibitors, probably through the weight reducing effect is beneficial, and this drug is beneficial in diabetic patients with heart disease, liver disease, kidney disease. So this drug probably through the weight reducing effect is beneficial in NAFLD with advanced disease. Statins, I want to emphasize statins because they are safe and they have benefits, and statins are good for all form of liver disease, especially advanced liver disease like fibrosis and cirrhosis. And we should not be stopping statins if they are on statin for another illness like diabetic indications, so ischemic heart disease indications, so hypertensive indications. Statins have a lot of benefits like reduce angiogenesis, inflammation, improving endothelial dysfunction, and reduce fibrosis. So if they are on a statin, please do continue statin. Summary, progressive NAFLD is mostly food related. Gut microbiome and genetics play a major role. Fibrosis stage predicts survival, can be reliably diagnosed non-invasively now. So FibroScore and the FibroScan should be done, because just the AST/ALT and the ultrasound will not be able to pick up the patients who are at risk of fibrosis. Lifestyle modification is the key. You reduce 10% weight, then it can reverse the fibrosis. Comorbidities should be carefully taken care of, especially diabetes, hypertension, and hyperlipidemia. Statins have a role to play, but appears underused. Pharmacological breakthrough still awaited. Available option reserved for patients with advanced fibrosis. Thank you very much for your patient hearing.